I'm going to talk about H. pylori infection, the optimal testing strategies, who to test, when, and how. When I get this really question, I thought it's just 3 or 4 slides will answer this. But being in the IGCC and without talking about the gastric cancer, without talking about H. pylori and its role, it might not be optimal. So I will actually concentrate mainly on the gastric cancer and the role of the H. pylori, and at the end, we will go and discuss the 3 questions. So as you know, the H. pylori is a gram-negative bacterium that selectively colonizes the human stomach, and most prevalent chronic infection in the world, causes a chronic gastritis which might progress to PUD, multiple lymphoma, and gastric cancer, and high impact pathogen that might cause mortalities and of course morbidities. And the Kyoto consensus classify H. pylori gastritis as an infectious disease that has to be treated. And the Maastricht Florence consensus recommend the treatment for all infected individuals irrespective of the clinical symptoms. And as you know, H. pylori associated with many gastric and extragastric conditions, including non-ulcer dyspepsia, gastric ulcer, duodenal ulcer, gastric cancer, and multiple lymphoma, plus idiopathic thrombocytopenia purpura and iron deficiency anemia. Keeping in mind that 60 to 80% of patients with H. pylori are asymptomatic. And there is a potential actually cure for H. pylori, but there is always balance between the benefits and the harms that you might get from the treatment, and probably the benefits are overweighting the risk of the treatment. So the prevalence, 50% of people worldwide are infected with H. pylori, mainly in the developing countries. When you move to the developed countries, up to 20%, and in the Middle East, it's up to 70%. This is from the regional consensus that was actually published this year. We can see Saudi Arabia between 40 to 70%, in Iraq up to 70%, and some countries up to 80%, including like Turkey, and 70% in Iran and other countries. So we know that the H. pylori prevalence in Saudi Arabia depend on the geographical region, diagnostic methods, and the period of the studies, and the reported prevalence range between 70% in the old days and reaching up to 10% before the COVID era. For gastric cancer, we know the etiology is multifactorial. It lies between the diet, genetics, and we should not really skip or forget about H. pylori role. And you know the Cure's hypothesis about H. pylori infecting usually a normal mucosa, and if it's left alone, it might lead to atrophic gastritis, small intestinal metaplasia, colonic metaplasia, which are up to this stage is reversible. So if you catch the H. pylori at this stage, you might reverse and prevent dysplasia and gastric cancer. So Dr. Al-Fadda already talked about gastric cancer. It is the 5th most common cause of cancer death worldwide. In 1994, WHO labeled H. pylori as type 1 carcinogen, and it is in the result of the number of mutations, and eradication can lead to reduction in the incidence of gastric cancer. There is a nice paper that was actually published this year about a global lifetime estimate of expected and preventable gastric cancer across 185 countries. As you can see, this is actually a global just expectation of what happened to those patients who are at risk of H. pylori, what will happen to them over time. So there is 15.6 million lifetime gastric risk across this cohort, 70% of them attributable to H. pylori, and 75% actually they are in Asia. This is the table from the study. As you can see, there is 1.3 billion people at risk of H. pylori, and out of those, 15.6 million will develop gastric cancer. And the gastric cancer are usually the non-cardiac caused by H. pylori and can be prevented by the treatment. And in 2013, the recommendation is actually to screen people who are at risk of the H. pylori and eradicate the infection to prevent the cancer. A systematic review of randomized controlled trials and observational studies being published recently, and this is a nice paper that was published showing that eradication will actually reduce the risk of cancer. On the left side, you can see there is randomized control trials, 8 studies, and on the right side, mirrored by observational cohort studies, 11 of them, both of them showing that eradication will actually reduce the cancer risk. We know the study that was published actually a few years ago from China, which was really prospective, started in 1994. So it was very interesting. 1,600 patients randomized into those are already infected with H. pylori and randomized to either to be cured and treated and cured, or just follow up with endoscopy for up to 26 years, and expected that patients who are not really treated get cancer more than those patients who has been treated and cured. So there was a 43% reduction in all types and 63% on patients with precancerous conditions. So based on that study, when it was published, the Chinese adopted what you call screening program in the families. And they did what you call the Delphi questionnaire, and they put like experts from different universities, and they ended up by having some recommendations. There's no time to go through it, but actually they adopted family screening, because if there is one member in the family who is infected, can spread the infection even for those who has been recently cured. For transmission, as you know, we don't have really a clear cut answer how the infection is really transmitted, but most likely fecal oral and contamination. Now answering the questions of Dr. Ahmad: who to treat, when to treat, and how to treat, or how to test actually. So the indication for testing is basically, we published already in our guidelines a few years ago, which actually to be tested and to consider testing, and we listed actually 10 indications for testing H. pylori, plus others like to be considered. But the most important that you should not really forget that never test a patient who is not really candidate for treatment, or who is not interested to be treated in the future. So we don't test any asymptomatic individual without risk factors, a GERD without dyspepsia symptoms, and patients who are unwilling or unable to take the eradication therapy. So test and treat for management of dyspepsia. As you know, dyspepsia is a very common condition. We see it in the general practice. It's a range of upper GI symptoms. And based on the Maastricht 5th consensus guidelines, recommend test and treat of patients less than 45 years old with dyspepsia, consisting of non-invasive H. pylori testing then followed by eradication therapy. If the patient is above age of 45 or have alarm features, they have to go for endoscopy and test for H. pylori based on the endoscopic testing. So what tests we are using? As you know that we have many tests. We have non-invasive and non-invasive. We do serology. The problem with the serology, it doesn't tell you if there is any active infection or past infection, because antibodies last long in the blood. So we do it sometimes for patients who are actually, for example, bleeders, or patients coming to the clinic and they need a quick test and they have never been exposed to antimicrobial treatment for H. pylori. The most common test that we are using in practice is urea breath test and stool antigen test, and both actually equal with regard to sensitivity and specificity. Most of the guidelines actually they go with UBT for 2 reasons. It's slightly more sensitive and specific, and also for patient preference. Many patients, if you give them the 2 options, they will go with UBT. If you are going to do the endoscopy for any indication, rapid urine test is very good, and I always recommend to take 2 biopsies, at least one from the antrum and one from the body, and you have to put it in the same disc. Histology is very good, and you have to take at least 5 biopsies from different, according to the Sydney protocol. The good thing in the histology, it will tell you also if there is like any other pathology, like atrophic gastritis, eosinophilic, or other like pathology in the stomach. Doing culture is challenging, and I think very few hospitals within the kingdom doing the H. pylori culture. As you know, when you take the culture from the stomach, you are putting it in the media. Still, the forceps go through the chain of the scope. It can get contamination or from the scope, from the mouth of the patient, and you put it in the media. And sometimes you go and get false negative result or false positive for another organism. What we are waiting for in Saudi Arabia is to get the PCR assay, which is very good test. You can do it from the gastric mucosa. You can do it also from the stool. It's a very rapid, quick test with excellent sensitivity and specificity, and it will tell you about the result of the antimicrobial resistance. I think I stress on my colleagues and my fellows to always use the Sydney protocol to take the multiple biopsies. So I usually take 7 biopsies, 2 for the flow test and 5 for the histology. So for PCR, it is very rapid. There are different countries, American laboratories, and different companies who are doing this test. We have actually tried to approach one of the companies, but the problem is the cost. The cost of this test, because they are doing PCR in 2 hours, and you will get the answer with the sensitivity for all the antimicrobial that we are using. The 6 of them, are they sensitive or not? Important point is to confirm always the eradication. Once you treat, you have to know, are you doing a good job or not? So post eradication is crucial and it's recommended by all the guidelines. It reduces the risk of recurrence and gastric cancer, and you have always to do it off treatment with PPI for at least 2 weeks and antimicrobial and bismuth for 4 weeks. Using the UBT or stool antigen confirmation test is the one that you use, but not serology. The problem is the adherence to the post-eradication testing. We don't have really data in Saudi Arabia, but I know many of my colleagues, they do it, but in general practice, they don't do it. They just treat and they assume the patient has been cured. It's very important, and it's in all the recommendation that you have to do the post-eradication testing. So as you can see from the European registry, the adherence was very good, 98%, but if you go to the US community hospital, it dropped to 16%.
2 minutes.
There are special situations like bleeding ulcers. When you encounter a patient who's bleeding, do you take a biopsy for H. pylori? There is a big debate. The GI bleeding might cause a false negative test. So usually we do either multiple biopsies and do it for PCR. And recent also antibiotic exposure, always make sure that 4 weeks of antimicrobial for any reason. The patient use it for UTI, for upper respiratory tract infection, or pharyngitis. They have to stop it for at least 4 weeks because it might lead to false negative results. Also, the proton pump inhibitor for at least 2 weeks. Using the H2 receptor antagonist is permissible, but you have to allow the patient 1 day off because it might interfere with the test. In children, usually we prefer non-invasive testing. Now moving to the treatment by itself is a lecture. Nowadays we have more than 20 to 25 regimens for treatment of H. pylori, and this has been already explored in our publication a few years ago. So we put the guidelines, we put all the recommendations, and based on that, we actually followed this in the recent consensus by my colleague Dr. Ala that was published this year. We looked at actually according to the clarithromycin resistance, if it is low or high. We know in our area it is more than 15%. In our hospital, it's 23%. So we go with the right protocol. We go with the single capsule BQT. If this has failed, we move to the levofloxacin. If this has failed, we can consider rifabutin triple therapy. Using high dose amoxicillin with PPI, it has never been tested in our area, but it is really a place for studies in the future. So I have 30 seconds to go through the take-home message from this presentation, that H. pylori testing should be targeted, not universal. Test only when the treatment is indicated. Non-invasive testing like UBT, stool antigen tests are preferred in the most cases for diagnosis and follow-up. Avoid testing during the PPI or antibiotic use. Confirmation of eradication is essential for clinical management, and follow-up or following the evidence-based guidelines for testing and treatment is really important. Thank you so much.
Thank you, Professor Fahad.